Okay, so what we're going to end up with all of this atherosclerotic plaque development over the span of hopefully decades, and not hopefully by the time you're 27, is ischemia. You're going to have a decreased oxygen and nutrient supply to the distal muscles, the muscles that are being supplied by that blood vessel. That's the job of blood vessels, right? So that's going to alter coronary perfusion. A large stable plaque was going to alter perfusion. If we have a sudden vasospasm event, that's going to suddenly alter perfusion. Poor perfusion pressure. And all of that can lead to angina pectoris. Our first sign that something's wrong typically is angina pectoris. Or pectoris, I don't care how you pronounce it, chest pain. It's going to follow a referred pain pattern. It's usually going to be in the pectoral region. It's going to feel like burning, crushing, squeezing, choking, and it may refer down further. Now, in the case of angina, there's no permanent myocardial damage. You're not in a heart attack. It's not a myocardial infarction at this phase. It's just a sort of low-grade ischemia. That's what's registering as painful. As I understand it, there's a typical pattern, but yes. And also with some of these, I don't know if it's true for angina pectoris, but it's definitely true for myocardial infarction. There is a biological sex difference between the referred pain pattern that men get versus the referred pain pattern that women get for myocardial infarction. So I would imagine this would potentially be different too. Okay, acute coronary syndrome. We will have a couple of things that are acute coronary syndrome. Most common that you'll see is going to be myocardial infarction, MI. That's a heart attack. That's a fancy heart attack word. That means a complete occlusion of a blood vessel has occurred, and the cells that are being supplied by that blood vessel are going to die. You already know about reversible and irreversible cell injury in response to ischemia, so that should make sense. It could be because a plaque ruptured or there was acute thrombus development, or it could actually, there can also be an unstable angina in which there is a partial occlusion. That's separate from a myocardial infarction. But we're going to focus on myocardial infarctions. We will have ECG patterns for myocardial infarction. We'll also have some biomarkers and other lab tests results that are going to tell us not only that they're having an MI, but how far along they are after their initial onset of the myocardial infarction. After a myocardial infarction, what we're going to see in the tissue is death of the tissue. We're going to see a form of necrosis, and this is going to be permanent. These are muscle cells. Adult muscle cells are non-mitotic. You are not getting those muscle cells back. If healing can occur, if this person survives and healing occurs, it's going to be replaced by scar tissue, which will be non-contractile. So, what's up? This is going to be left ventricle. This is going to be right ventricle. You can see we're going to talk about cardiomyopathies in just a bit. This is an example of cardiomegaly. They've had issues for a long time. So you have hypertrophy of the myocardium right here, and then you have this flabby patch that shows you there's been death of the tissue right there. So that's the lumen of the left ventricle, and you can see lumen size is greatly decreased because of the cardiomegaly. Yeah. Yeah, it's a weird picture, absolutely. You're right to see it as abnormal. It's a good catch. Okay, acute coronary syndrome, some possible ECG patterns or EKG. Again, I say ECG because cardio starts with a C. In German, cardio starts with a K. That's the only difference. First of all, you can have an elevated ST segment. We've got our standard curve up, our waveforms up here, PQRST. So the ST segment is simply from the end of the QRS complex to where the T wave should start. If that appears elevated, we call that colloquially, what do we call it? STEMI, exactly. You could also have an inverted T wave. So those are just some common ECG patterns that indicate myocardial infarction has occurred. So instead of that T wave being on the positive part of the y-axis, the T wave is inverted into the negative side of the y-axis. And again, if somebody's having an MI, there can be excruciating chest pain. It may radiate to the arm, shoulder, and at least your textbook includes jaw or back, which are the more female patterns. Women are more likely to experience jaw pain or nausea or back pain in conjunction with an MI, whereas the male preferred pain pattern is more the stereotype of the left arm. Right? And of course, the publicly known one is the left arm one, right? That's what the PSA was about. Exactly, because women didn't get the PSA that says, oh, your jaw pain, your nausea, your back pain could be an MI and you should have that checked out. It could be days later before a woman gets checked out, and now the destruction to the muscle cell is done. Vague symptoms, yeah, absolutely. Not feeling right. Honestly, not feeling right is kind of part of the female condition, just in general. So we're not really likely to get that checked out. I'm definitely on team not getting it checked out when I should be getting it checked out, personally. I went an entire week with absolutely terrifying neck pain before I went to urgent care once, and it turned out to be something serious. So, yeah. So don't be like me. There's our inverted T wave. Again, this is a teeny tiny little baby version of an elevated ST segment, but there you have it. And that's just our typical ECG pattern, showing you P, QRS, and P. Sometimes a U wave. Who gets a U wave? Some people will get U waves. What did you say? You don't know. I'm gonna say if it's wrong anyway. I don't care. Just say something. No, babies probably won't have a U wave. Some people will get ablation probably. Athletes, maybe if you have a really, really low heart rate for some reason, that may give you a U wave. And there's another population somewhat correlated with that, but not necessarily. The elderly. Elderly may have a U wave. Other way. Okay, so some serum marker changes. And again, if you remember your cell biology for muscle tissue, some of these should make sense. So myoglobin first. Myoglobin is a molecule of protein found in muscle cells. So myoglobin would be the first biomarker within the first, 5 hours of an infarct onset, followed by elevated troponin and CKMB. I do have a note here in my notes for what CKMB is. It's the enzyme. It's variants of the enzyme phosphocreatine kinase. And I think that's what you came to my classroom asking about creatine phosphate the other day. No, that's okay. You're allowed. That's interrelated to this concept. You're going to have creatine phosphate as a sort of alternate energy source in your muscle cells, and that's going to be released on muscle death, is what we're saying. It is in your notes as well, enzyme phosphocreatine kinase. And you guys know what troponin is? What's troponin? It's in the muscle cell. What role does it have to play in muscle contraction? It's one of the. That's the myosin head. It's not. I'm just doing the muscle contraction movement. But how did we bind to this? What was around it in the first place? Yeah, tropomyosin's the thread. So what's the troponin? It looks like a little snowman. Yeah, once it binds calcium, the troponin moves the tropomyosin away from myosin head binding sites. Yep, and then you can do that. How are my quiet people over here feeling about that? Are we following? Okay. Just nodding along and being like, yeah, I get this, not like, no, I don't get this, but I'm going to pretend that I do so that she keeps moving. Okay. That's what we're going for. Got the quiet quadrant. You always sit as far away from me as possible if you're quiet, so. You all keep picking up because you're up for it. Okay. So you don't necessarily need a sudden onset myocardial infarction for the death of cells to occur. There is also chronic ischemic cardiomyopathy that may not register as a heart attack, But nevertheless, there's enough ischemia to kill cells gradually. And that's eventually going to lead to heart failure. So as I'm saying some of these things and how they interact, angina, myocardial infarction, heart failure, start kind of putting them in order because there is going to be a timeline for you today. I usually don't put timelines on my worksheets. It's a new format, and it's mostly working out. Kills cells gradually, and that leads to heart failure. So you can kill cells quickly, and that can lead to heart failure. Or you can kill cells gradually, and that can lead to heart failure. So heart failure, we're going to get to that in just a minute, just means that the cardiac muscle is unable to contract enough to move blood forward. That's heart failure. Heart failure doesn't mean you're dead right now. You're in heart failure. You could spend months or years in heart failure.
So this chronic ischemia, is that what you see like with the patients that have chemo for a long time when they were younger and then they
Absolutely, yeah. Chemotherapy would be a good way to kill some heart cells in a chronic way. Yeah. I imagine there's an iatrogenic form of this. I've never heard of that in terms of this before, but it makes sense. It follows. Okay. Yeah, absolutely. I agree with that entirely. Yes, you can spend years in heart failure. My grandma's still alive somehow, but she's been in heart failure for like a year. Okay. Again, we can go back to that concept of the layers of the heart. You have an endocardium, you have a myocardium, you have an epicardium. The myocardial damage is that like myocardial infarction. That's that middle layer. Now let's move to the inner layer, the endocardium. So we have a sort of epithelium just lining the lumen of your atria and ventricles, but your valves are also comprised. Part of your valve structurally is the endocardium. So if you have an endocardial disease, chances are your valves will also be impacted by that. A lot of endocardial diseases either are or create valvular disorders.
Are there anything, I might be thinking of the wrong things, that you're born with that like
Yeah. Yeah. Yeah, we'll get to congenital heart defects in just a second. We can have some weird valves, absolutely congenitally. Stenosis. Stenosis is actually going to cause two things. I actually like this image for stenosis. So stenosis is, it could be related to stiffness of the valve. If your valves are stiff, they are going to be unable to close all the way, and they're also going to be unable to open all the way. It's problem twice, right? What's the problem if it can't close all the way? It's going to reflux into, it's going to go backwards in the heart if it can't close. If it can't open all of the way, what's the problem there? Yeah, you're not going to be able to fill the ventricles very well, or the next thing down is not going to fill. You're not going to move things through very well. So a stenotic valve, a diseased valve, is going to be a problem in two ways. It's going to be a problem twice. So regurgitation or insufficiency means that we're going to have regurgitation into a prior place in the heart. We're only supposed to move blood one way. It goes the other way. And then stenosis, failure of it to open completely. It means the heart is going to have to work harder. Both times it means the heart's going to have to work harder, right? If it can't fill all the way, you're not going to have as much blood volume in your ventricle when you contract your heart. What do we call that blood volume that gets ejected? Stroke volume. So you're going to have low stroke volume, which is going to impact what number that's really important to us? Cardiac output. Awesome. I like how fast that was. It's a good sign. Okay. And then it's also going to have to work to push things forward through a stenotic valve. So there's more work either way. The mitral valve stenosis being a very big one. When we have the mitral valve, of course, it's impacting the connection between the left atrium and left ventricle. And we're going to have everything I described on the left side of the heart, which we know is pumping to the body. Here's this concept here, where this is just the first time we're seeing this. This is sort of what your worksheet was preparing you for last time. Pulmonary hypertension. Why is pulmonary hypertension here? Yeah, why do we have pulmonary hypertension after mitral stenosis? Because of the backflow. So anytime that things aren't moving forward, they may be getting stuck backwards. Backwards from the left side of the heart, that's the lungs. So we're going to see that with a lot of things. We're seeing it with mitral stenosis. We're going to see it with left-sided heart failure. We're going to see it similar problems with a number of heart conditions. Yeah, absolutely. Okay. There we go. Do you guys remember the normal pressures chart from AMP2 that we spent all that time on? Nora's like, yeah, I do. Can't ever forget. Having flashbacks right now. You should be having flashbacks. You should be having some flashbacks to that pressures chart because that was the normal. And now we're going to start seeing some abnormals. There's our pressure in the ventricles from mitral stenosis. It's going to be severely altered. You're going to keep seeing that pressures chart. I've shoved it down your throat on purpose. Hammered it into your brain meats permanently. In your brain meats. Everything. You're made of meat. It's all meat. It's meat all the way down. Okay, and another issue is that mitral regurgitation could lead to left-sided heart failure. There's going to be enough problems systemically in your heart that you're going to get some left-sided heart failure, which we'll get to into a second. It doesn't have to be about stenosis. It doesn't have to be a stiffening effect. Some people will have a ballooning effect. Mitral valve prolapse is a ballooning that, once again, is going to cause regurgitation, and it's not going to be able to close properly to move it forward. So the difference here is that it's looser and ballooned. It might be related to, say, like a connective tissue issue, for example. This might be something that's genetic and congenital. Yeah. My mom has a minor mitral valve regurgitation. And so my cardiovascular guy, my cardiologist, really wanted to test me, but I decided he was padding his bill, so I didn't get tested for it. Yeah. It was completely unrelated what I had going on with my neck. And he's just like, can we echo your heart to see if you have a mitral valve problem? And I'm like, right. He just wanted to test me for everything. If you have a mitral valve regurgitation, if it's minor, there's really nothing to do for it. You just know you have it. Yeah, they used to do like some prophylactic stuff. If you knew you were going to have like a dental procedure done, they would put you on antibiotics for a couple of weeks beforehand in case there's like an infectious pathway. They stopped doing that. There's too many problems with antibiotics anyway. So, yeah, getting worse infections, antibiotic resistance. So yeah, my mom would always be put on antibiotics before like teeth cleanings and things like that, but she stopped doing that. Okay, so there's an image of mitral valve prolapse. Hopefully you can recognize that this cusp is not supposed to look like that. That's the goal there. Other valves can also be stenotic, aortic stenosis. Here we go, calcium deposits. Fun fact, when I was in cadaver lab, when we did human body block, we got to CT our cadavers before we dissected them, which was awesome. I still have those somewhere. And with all of 3 of our cadavers that we got to CT, all of them had calcium deposits throughout their cardiovascular systems to different degrees. Their ages ranged from 45 to 95, with my 95-year-old having the most serious calcium deposition. So along with that like sort of lipid buildup, there can also be calcium buildup. We can calcify the blood vessels. And I'm not exaggerating when I say, when I reached into my cadaver's abdominal cavity and touched her aorta, it felt like Doritos. They were crispy. You could crush them, like, because they were so calcified. You could see it in the CT scans as bony deposits throughout her blood vessels. It is wild. And it was in all of them. All of them. God. No, they were not related. I can tell you for sure. The male cadaver had cardiomegaly in addition, and he had the pacemaker. And yeah, mine was a 95-year-old who died of dementia with failure to thrive. And totally, she'd had 2 bypass surgeries though. And at least 2 bypass, probably 3 bypass surgeries.
do anything.
Cleared out. I don't know.
That's what I was
Probably dietary, exercise, yeah, and inflammation being a big part of it. Stop eating cookies every day, Reeves. Okay. And again, there's our pressure charts, and here's some changes in the aortic pressure as a result of aortic valve stenosis. Rheumatic heart disease, I feel like probably Rachel goes into rheumatic heart disease. Does she do rheumatic fever really hard? Last quarter, people mentioned rheumatic fever really hard. Okay, never mind then.
She did heard that quarter because there was somebody that had rheumatic fever. So
Okay, gotcha. Okay, so somebody had an A beta hemolytic streptococci, and then our immune system started attacking our own tissues, especially in the heart. That's rheumatic fever. Okay, and of course that's going to be still of the endocardium. That's the part that's affecting. Infective endocarditis, if an infection makes it into the endocardium and infects it, it's going to be inflammation of the endocardium. It could be strep and staph, could be other things too. There's also, is there a viral form of this? I could be confusing it with something else, ignore me. Okay. Back to the myocardium. We already did myocardial infarction, but we're now on in sort of infectious pathways. Myocarditis means inflammation, infiltration of inflammatory substances like white blood cells into the myocardium. So if you're good histologically, if you remember your histology, you might be able to recognize the branching pattern of a myocardial cell, a myocardiocyte, cardiomyocyte, there we go, got it. Cardiomyocytes over here. And then these dark purple dots, those are all white blood cells, just interspersed within those cardiomyocytes. This would be common for viral infections that will impact the myocardium or immunomediated. And again, what we're concerned about is the structural integrity of the myocardium at this point. Once again, we're going to end up with a flabby patch, much like we did with the myocardial infarction. The difference is this isn't necrotic tissue, this is inflammatory tissue. So that brings us to cardiomyopathy. There's not just one cardiomyopathy, there's several types. There's a dilated cardiomyopathy in which that flabby patch has made like a loose structure of the heart wall. So it's less contractile, it's flabby, it's more extensible. It's just going to be too loose. It's not going to be strong, it's going to be loose. So you might actually have more ventricular filling, but it's still not going to be very capable of contracting to move that blood forward. So it's going to appear dilated as it fills but can't remove. One we've addressed several times before is a hypertrophic cardiomyopathy, like cardiomegaly would be a hypertrophic cardiomegaly, in which the size of the ventricles, most commonly left, but it could happen on either side depending on where the pressure is, where we have hypertrophy of the cardiac muscle cells that decreases the size of the lumen and increases the size of the heart and the space it takes up in the mediastinum. And then restrictive if the ventricles become rigid, if the muscle cells become inflexible, lose extensibility, lose contractility altogether. So again, cardiomyopathy is not one thing, it's multiple things, but they'll have a similar outcome regardless. The similar outcome regardless is going to be inability to move blood forward. And we're going to call that heart failure when we can't move blood forward. Pericardial diseases, we've moved from the endocardium, the myocardium. The epicardium, remember, is part of the pericardium. You've got multiple layers of the pericardium. Does anybody want to give me all those layers? You did it on your worksheet. An AMP2. What's that? Fibrous pericardium is most superficial. That's the big, thick, tough one. And then we have the serous part, always divided into two, parietal and visceral pericardium. Boom. You're rocking it today, Ellen. You did go over that picture 1,000 times. Honestly, just the fact that you kept that worksheet and you're referring to it, I'll take it. That's why you keep your worksheets, everybody. Keep your worksheets. I'm still having a hard time with my new cohorts convincing them to keep their worksheets for some reason. Yeah. I handed back, I like kept people's week 10. I'm going to pause this for a second. Some categorizations for pericardial diseases. They can be a result of systemic infections, traumas, metabolic derangement, something can go wrong with your metabolism, and of course neoplasia. So the first thing we're going to talk about is pericardial effusion. And that means there is some kind of fluid within the pericardial cavity. In between the visceral and parietal layer, there should be just a little bit of liquid. That's serous fluid, right? If it's anything other than that fluid or there's too much of it, that is bad, right? We don't like things aside from a thin, small amount of serous fluid in that space. So you can have overabundant serous fluid, serous sanguinis, chylus, or blood, and those are all going to lead to cardiac tamponade. I wonder if the thing that fell out was a clot. It was probably, yeah. Absolutely. So what's happened here with cardiac tamponade is fluid has made its way into the pericardial cavity, so much fluid that it's squeezing the heart. And when the heart is squeezed, it cannot fill. And when it cannot fill, there's nothing to move forward. So remember, that's going to be our preload. The way our blood flows into our heart is preload. Really important number is preload, right? So cardiac tamponade is going to impact your preload, which means you can't move blood forward. It's unable to relax, so it's unable to move forward. Manifestations, reduce stroke volume, obviously, and you're actually going to try to increase your heart rate. The muscle's still working, it's just not filling. So it can still have those compensatory mechanisms for cardiac output when cardiac output goes down. Hypotension, distended neck veins. Why distended neck veins? It's backing up into the body. Yeah, the jugular vein drains to the brachiocephalic, drains to the superior vena cava, goes back to the right atrium. So right side of the heart, right? Backs up into the jugulars, visibly often. I learned a really neat trick about that from my friend who literally just finished medical school the other day. Just finished it. He talked about somebody was experiencing some hypertension and liver failure, but they didn't have distended neck veins. And at their clinical site, the guy was like, if you compress their liver, you can watch their jugular just like fill up. Yeah, it was really cool to hear that. I didn't get to see it, but I get to hear about it. I know, I want to see it. He's going into pathology, so it's totally relevant. Okay. Yeah, where are we? Okay, so pericardiocentesis, that's where we stick a needle into the pericardial cavity and withdraw the fluid. If you're still bleeding, it's going to come back. You got to take care of the bleed. If it's lymphatic, or chylous or exudative, you got to take care of the thing that's causing that, right? I've also on autopsy seen this incorrectly performed. And we don't know if that was cause of death. We think he went down and died and the emergency medical people were practicing on him. At least that's what we're hoping, because otherwise they killed him. They stuck the needle through the pericardium. They went a little too far to the left and popped the pleural membrane in part of the lung. And they also went too deep into the pericardial cavity and popped part of the heart wall. Yeah. Right. Yeah, I'm sure there's a way to tell if you're doing it right versus doing it wrong. I got to see it done wrong. It was amazing. I really hope that guy was already dead when they did that. I'll never find out. We never get to find out, actually. Okay, acute pericarditis means there's an inflammation of the pericardium, obviously, usually presumed viral. We don't always know what causes acute pericarditis. There's also chronic pericarditis. For every inflammatory condition, there's going to be acute and a chronic form, and that remains true here. This is something I also got to see in my cadaver, where she'd had multiple heart bypass surgeries, and her pericardium was scarred over and was actually adhered. So she had just scar tissue instead of pericardium on the anterior surface of her heart. So that would be an example of adhesive mediastinal pericarditis. It sounds like a complicated word. Let's break it down. The pericardium in the mediastinum is adhesive to the wall, right? And that means it's not gliding. It's supposed to prevent friction and not stuck. Can't. It's going to tug. Yeah. This would also give you constrictive pericarditis, potentially, or you could have a form of chronic pericarditis that leads to constrictive pericarditis. We talked about cardiomyopathies being restrictive, but you can imagine a constrictive pericardium is also going to impact ventricular filling, preload, stroke volume, all that good stuff. Okay, let's talk about the congenital heart defects. We've got about 6 minutes before lunch. I think we can get through them once. We may need to review them when we come back to lunch. You guys tell me what you need. Now, again, we haven't done our congenital/genetic lecture, or we've done genetic, but we haven't done congenital or embryology lecture just yet. So you kind of have to roll with this idea of being born with heart defects until we talk about embryology, which I actually believe might be next week. So you'll understand how these things happen a little bit better next week, or I could do a little bit of mini embryology with this if you want. It's actually not that bad. It's like balloon animals. I think of it like balloon animals when you form the heart. So I'll show you the balloon animals. That's all I'll do. I'll talk about it more next time. In general, when we can categorize congenital heart defects, we categorize them as cyanotic or acyanotic. Are you turning blue or are you not turning blue? Most of these are going to be acyanotic. When people say that they have a hole in their heart, most commonly what they mean is an atrial septal defect. Most commonly, it's not a hole in the wall of your heart. It's a hole between the chambers of your heart. An atrial septal defect is going to be the most common one of those. The reason for this is that during fetal development, you are supposed to have an opening between the right and left atrium. It's supposed to be there. So embryologically, what you actually have at the atrial septum is two membranes next to each other. And one's got a hole kind of high up and the other's got a hole kind of low down. So during fetal development, it's kind of low pressure in both of the atria, and they can just share blood between them through these two circles that are unevenly spaced, right? Then the baby's born, it takes its deep breath, and the left ventricle fills from the lungs for the first time, and that increases pressure in the left atrium. If I said ventricle a second ago, I apologize. You're in the left atrium, and it fills with blood, and that increases pressure in the left atrium, and that slams the two membranes together. And because that hole was here and that hole was there, it closes. And then that's going to scar, effectively, physiologic, good scar, the good kind, between them, and there's no longer an opening. I'll finish this thought and then I'll get to your question. Most commonly in atrial septal defect, all that needs to happen is for those holes to be more aligned.
Is that the foramen ovale?
Yes. So it was a foramen ovale before you were born, and then after you're born, even in the adult heart, we can see a remnant called the fossa ovalis. Yeah. So even if we don't have a hole in our heart, we do have a fossa ovalis. We have an indentation where the hole was, yes.
So this is not something you would ever know if that was going to happen before you have to see it after. Or could you know because they were too aligned?
I don't know. Karen Riley question. Ask what prenatal tests there are for this. There probably are. I just don't know what they are.
For ventricular, you can see.
For ventricular, you can see?
Oh, yeah.
Okay.
My daughter has that.
Yeah. I imagine there's a way to see it. I just don't know what it is. It might be on ultrasound. That's just a guess, though. Okay, so this will be acyanotic. When you have mixing of oxygenated and deoxygenated blood, you're still pushing some degree of oxygenation around. So it's not the most serious heart defect there is. There's a ventricular septal defect. It's actually embryologically going to be a little bit different. There's no stage where you're supposed to have a hole here, so it just means there's a failure of the septum to develop, right? It's a little bit more serious. It's still going to be acyanotic. Once again, you just have mixing of oxygenated and deoxygenated. You're still pushing some amount of oxygen forward, so it's acyanotic. Go ahead and ask it, and if it's...
Well, my daughter had that. She had a whole bunch of heart stuff, but with the ventricular, she was immediately blue when she was born.
So she probably had something like this that would have been multiple.
She didn't have to.
It wasn't the tetralogy.
No,
but it was.
Wanted to call it that, but she didn't have that.
Yeah. They're on the same page as I am. So she probably had some combination of them, at least one of which would have caused a cyanotic defect. But it wouldn't have been the ventricular septal defect that caused cyanosis.
Okay.
Yeah.
That's what they said, concept of
yeah. We will get to that concept in just a second. So next one is patent ductus arteriosus. Once again, during fetal development, you have a physiological ductus arteriosus. It means that you mix oxygenated and deoxygenated blood a second time through the aorta and pulmonary trunk. It's supposed to be there before you're born. Then you're born and it's supposed to scar over, and then it becomes a ligamentum arteriosum. So if you were to dissect an adult heart out, you would find a ligament attaching the aorta to the pulmonary trunk. It's solid, right? It's not a hole. So again, all this needs to happen is it stays open. It's just a patent ductus arteriosus. So again, acyanotic because it's simply mixing oxygenated and deoxygenated. You're seeing the pattern here of if it's purple, right? If it's mixed oxygenated, deoxygenated, there's still some oxygen moving forward. Not as big a deal. Coarctation of the aorta means that part of the aorta is thinned in a congenital fashion. It's not a thrombus. It's just, here's how it looks on this image with contrast in the aorta, and you can see it's sort of pinched off in this one specific spot. That's coarctation of the aorta. And that just means your heart would hypothetically work fine to push blood forward, but it's going to hit like a literal bottleneck, and it's going to limit the amount of blood you move forward. It's still oxygenated, but you're going to have a weaker pulse in the extremities from a coarctation. Now we get to tetralogy of Fallot, and this is why I brought this up in conjunction with her question. This is a combination of multiple heart defects. In this case, it's cyanotic. So, pulmonary stenosis means the pulmonary semilunar valve, also known as pulmonic valve, is stenotic, which causes problems moving blood forward. An overriding aorta. So you have a ventricular septal defect, but not only do you have that ventricular septal defect, but the aorta has shifted so that it's actually going to receive blood just as much from the right ventricle as the left ventricle, right? And because you've got pulmonary stenosis, it's actually going to be easier to push blood into that aorta than it would be to go through that pulmonary semilunar valve. So far, so good? Still going. Because your right ventricle is unable to push things into the pulmonary trunk, it becomes hypertrophic. Now, something's going to go on with some of these multiple congenital heart defects at the same time. This is cyanotic for some of them. If you have an additional atrial septal defect that allows for mixing and of oxygenated and deoxygenated blood, that can actually be protective in some of these cases. So in this case, you're never getting oxygenated blood to your body and you're never getting deoxygenated blood to your lungs. If you mix them and have oxygenated and deoxygenated blood on both sides of your heart, that's actually the only way you're going to get any oxygen to move forward. Weird, right? Okay, so this is transposition of the great vessels. I'll come back to this atrial septal defect for it. This is very much where that embryology comes in handy. This aorta and the pulmonary trunk, they form from one structure. and then a septum divided them later, which also gives us truncus arteriosus. So here's what it looks like if that septum doesn't develop at all. Here's what happens if the septum develops, but the vessels are going to they're on the wrong side of the split. I always think of it like a balloon animal. So let me show you the balloon animal. What's that? It's wired wrong. Yeah, absolutely. Heart embryology. Your heart embryologically comes from the same tissue that your blood vessels came from. So what you're looking at is two different blood vessels, essentially, fusing into one trunk. And then, so take that as like your long balloon, and you enlarge certain portions of it, and you twist it back around itself to get the separation between atria and ventricles. So what was on bottom is now on top. What was on top is now on bottom. And now you have septa developing between the ventricles, between the atria. And here's the trunk that is going to give rise to all your aorta and pulmonary. All of your great vessels are coming from right here. So then you have a septum develop between those as well. Does that help make sense out of truncus arteriosus and transposition of great vessels? Yeah, it's pretty good, right? It's just balloon animals. I promised you it'd be okay. It was. Right. That's exactly what embryology is. It's freaking out about how much can go wrong. Yeah. Okay, so again, transposition of the great vessels, in this case, the right side of the heart is going to pump to the body, and that's deoxygenated, and that's going to be completely ineffective. The left side of the heart is pumping to the lungs, and it's already oxygenated. It's going to be completely ineffective. This is cyanotic and will kill the child unless they have an atrial septal defect, unless we can mix oxygenated and deoxygenated blood and get some oxygenated blood to the body. Unless we can get some deoxygenated blood to the lungs. With a lot of these, it's going to be surgery. If it's an acyanotic defect, we're probably going to wait for them to be a little bit older and stronger before we perform surgeries. And that's all I know about it, unfortunately. Another clinical question for a clinician to answer. Yeah, if it's more severe, if it's a cyanotic defect, this one is not going to be compatible with life unless there's an atrial septal defect. And that's it, and it's time for lunch.